Hello. Okay, can you see a button to unmute yourself?
Hello?
Okay, can you hear me?
Yes.
Okay, great. So you can unmute yourself, but I'm going to admit Susanne for the test.
Okay.
So Suze, you should be in any moment now. And Sascha. And I'm making Sascha co-host. Okay, so now I see, I hope Sascha can hear us. Ah, Sascha, yes, great. Hello. Sascha, you should be able to unmute yourself. And there are already quite some people in the waiting room. Well, okay, so Sascha, you're unmuted.
Yep, I can hear you now.
Nice.
How are you?
Good. Excited.
Yes, good.
Oh.
Me too.
Yes. Just trying to figure out Zoom because I haven't.
This is the thing, like I'm not sure, I've used Zoom before, but now looking at it, I'm not at all sure where the features are, but I see the share screen option is in the middle there.
Yes, and I'll share my screen now for just the introduction.
Yeah.
Let me figure that out.
I guess I should probably close anything else that's open on my computer, right?
Yes,
Because
or
otherwise
at
they
least,
might see
yeah,
other
minimize
things
them.
shouldn't be seeing. Good, I'll do that.
And by the way, Sascha, this is Enya. Enya is
Nice to meet you.
coordinator for the our work on vaccinations and vaccine
Okay.
hesitancy. Yeah.
Yeah, that'll be interesting as well.
Okay, so I'm going to try something. What do you see? Oh, this is the wrong one. That's not it. So, what are you seeing as a screen?
My screen's frozen and I'm seeing a loading sign saying EMSA host has started screen sharing, but I can't see your screen.
Do you see what
Okay, yeah.
Do you only see the slide?
Yes.
Okay. Maybe, I don't know, Enya, do you have the power to admit people to the room?
Not sure.
Do you see something on the right top?
Right top. No, I think it's only saying like I can leave, but I don't think I can admit other people.
Okay, so you have access to these slides?
Yes.
Could you open them and share your screen?
I'm actually on my phone because the camera on the laptop doesn't work. So
that's okay. You know what I will do? Sascha, you figure out the share screen part, right?
Yeah.
Okay.
I think so.
So I will admit people to the meeting and then we will start in a bit.
Sure.
I will stop my video because it's a bit awkward for the next few minutes.
Yeah.
That's okay. Is it, I'm just wondering, I'm kind of dark. It's very dark, the background where I am, but I can't really change it because it seems to be raining right now. I switched on the light, but that's not so good either.
It's okay.
Yeah.
I think the light is better. It's better with the light on than without the light on.
Better with the light? Okay.
Yes.
Like this? Okay.
Well,
yeah.
Because I guess you can see the lamp behind me there.
Yeah.
Not good? Okay.
No, you look like a holy person.
Yeah, the halo.
Okay, so I'm going to mute myself, close the window here because it's making noise.
Shall we do the same for now?
Yeah, and then at 5 exactly, I think we'll start 2 minutes past.
Sure.
But then we will do the introduction so I can show you because I hadn't sent it to you, but this is what will be looping. So it's just promotion.
Yeah.
But then it's very short, just about what we are, and then our team, and Enya and Safe will also introduce themselves, and then we'll go into you.
Okay.
So, and then you can take right away, and also make sure to explain how people can ask questions. So they should be able to write in the chat.
Yes, let me look at the chat. Okay, that's here, but how do I? Okay, now I've got it on my right. Because I should be seeing, in a way, I should be seeing messages as they're coming in, right? Ideally, on the right.
You should. Can you see them?
Yeah, I think I can see them now.
Yep.
Okay.
I figured out how to admit people, so if I can help out by admitting people, I can do that.
Well, actually, yes. Wait a second. Let me stop my video, and I will mute myself in a second. Let me just figure this out. Loop. Okay. So Enya, you go ahead and admit people.
Okay. Yeah, Safe is out here as well.
So for those who just joined us, we're waiting for the rest to join. We'll start in a couple of minutes. Make sure to mute yourself and preferably also turn off your video so we can have the best quality. Good afternoon, everyone. So for those who just joined, I will be waiting just 1 more minute and then start with the session. Make yourself comfortable, grab a cup of tea, coffee, and we'll be ready soon. Okay. Hi, everyone. I hope you can hear me. I'm Rana, and I'm the facilitator of this session. Welcome to the, well, it's the so many session of range that we've been having at EMSA, but welcome at the first dedicated to advocacy at the for European public health issues. I'll quickly start with some introduction of EMSA, of our team, and then we'll go into the session by our speaker, Sascha, who you can also see here. Yes, waving indeed. So bear with me while I figure this out. So, okay. I hope you can see the screen, the blue screen right now. Okay. Well, good afternoon again. Thank you for coming to the session. So this is a session organized by the European Medical Students Association. Some of you may know us, some of you may be a member of us. For those who are, thank you for supporting us. And for those who aren't, I'm very happy that you found this session. So the European Medical Students Association represents medical students across Europe. And we do work on a lot of public health issues on the European level, but also on the national and local level. And we felt that's very important for medical students, but also for all kinds of students and young people in particular, to be equipped with the skills to advocate for health issues in their context. So that's where the session comes from. Well, the team behind it is the public health pillar of EMSA. And the pillar consists of me together with Enya and Safe, who hopefully can join with their video in a sec. So together with Enya and Safe, we work on a range of issues in public health, starting from, well, vaccinations to climate change and health, but also preventing NCDs. So we advocate for a Europe without tobacco and a Europe where alcohol is being used moderately. And we do this together with a range of partners, for which the European Public Health Alliance, excuse me, is one of them. And that's where Sascha comes in. But before we go to the speaker, I would like to ask Enya and Safe to introduce themselves, where they come from, what they study, and what their role within the association is. So I hope you can unmute. Yes. Oh. Enya, go ahead.
Yes, you can see me? Yeah. All right. Hi, thanks everyone for joining this session. My name is Enya Quilina. I'm a third-year medical student at the University of Malta, the only university in Malta. Within EMSA, I am the public health assistant for vaccine hesitancy. And basically, I'm involved in everything to do with vaccines that EMSA does. So it's both the internal affairs and the external affairs, which includes working with a lot of valuable partners, especially within the context of the Coalition for Vaccination, which is led by the CPME, the Coalition of European Doctors, as well as the associations of European nurses and pharmacists. And yeah, we're really focusing on pushing back against anti-vax sentiments and really promoting the safety and efficacy of vaccines for preventing diseases. So that's me.
Thank you, Enya. And Safe? Oh, give me a second. Where's Safe? So I can't connect Safe. Sorry for that, but I will introduce Safe, and at the end, you can also speak with him. Safe is a medical student from Amsterdam, the University of Amsterdam, and he's been our well, assistant for climate change and health, so he does everything that entails our planet. And he's been mainly working on air pollution this year, and also on the topic of climate and health education. And of course, the sustainability of EMSA itself. I'm sorry to not be able to connect safe, but I hope you can speak with him at the end. And for myself, I have a medical background, but I switched to public health at the middle of my studies. So I'm a public health student from the Netherlands as well. And, oh, excuse me. And I'm the public health director for EMSA. Okay, so I'll go ahead and go to the session. So the session is about advocating for European public health issues. And I've already mentioned Sascha, who's the acting Secretary General of the European Public Health Alliance. And in this role, Sascha is the voice of public health in Brussels. And he's very, very kind. So I'm sure you will enjoy this talk. And Sascha, perhaps you could also quickly mention what your background is, because it's not medicine and it's not formal education in public health. It's a very interesting background. So please go ahead. I will stop sharing my screen so you can start sharing yours.
Thank you, Rana. I hope you can hear me all. And thank you so much for the opportunity to be here today. I really appreciate it. I'll bring up my presentation and then I'll start talking just to make sure this works. Yep, it does. And I'll put it into presentation mode, slideshow mode, I guess. Great. So yeah, my background. Already I feel humbled speaking to a large group of medical students and God knows what else you're studying, because yeah, I didn't study medicine. I didn't study public health. My background is in communication and cultural studies, mainly. I also have an undergraduate business degree. Really, it took me, to be honest, I feel like it took me a very long time to find my way. And as I was working in the public sector for a number of years, getting very bored, I was exploring my interests, and at that point in time, I had migrated to Canada, so I was working at the government of Ontario. I had a lot of free time. I was exploring my interests in migration, and eventually that led me to an interest in sort of migrant health, which by chance led me to public health, but I was already well in my 30s. So being the voice of public health in Europe is still something I'm getting used to. It's very strange, but at the same time, I think, and I think you will hear also from my presentation, I think public health is just so fascinatingly complex and interwoven and multidisciplinary that I think no matter what your background is, and I understand some of you are not only medical students, but you're studying all kinds of things, maybe public health could be your home in the future. That's all I can say. So without further ado, I'm going to begin my presentation. And the premise for this was a little bit my conversation with Rana last week, when we sort of discussed that public health advocacy has probably not been this relevant for a long time, given the COVID-19 crisis, but more importantly, the opportunities that are now arising from the crisis. So I think this is a very timely moment to speak to you guys and sort of see what is it that EPHA is doing, first of all, but also what are some of the upcoming opportunities for public health advocacy, and how you as medical students or other students could play a part through EMSA, through EPHA, or by working on your own or with other partners, okay? So I'm going to talk about EPHA, I'm going to talk a bit about advocacy, I'm going to talk about European public health, and I'm going to talk about seizing the public health momentum. And there's going to be natural sort of breaks in my presentation when we can have a bit of interaction if you like to do that, if you have any questions. I can't currently see any questions that are being posted, but Rana or Enya or somebody will probably interrupt me should there be any important ones. So EPHA, as Rana explained, is sort of the largest public health umbrella NGO advocating for better health in Europe, which means we are a network of networks. I already mentioned that EMSA have been members for a number of years and quite active, actually, despite the fact that you're turning over year on year and we get to know you every year, which is also nice. Fresh thoughts are coming our way. But let's say about 80 other different types of organizations are also part of EPHA, and they might be disease-specific organizations. They might be the organizations representing the interests of healthcare professionals, representing the rights, the health rights of vulnerable groups. They might be public health researchers, public health specialists. It's a really diverse group of people. And as you can imagine, it's not always easy finding consensus, but we try to do our best. We see ourselves as a kind of change agent for public health policy. And obviously, I will explain to you what we mean by that, because I think that's better explained through our ways of working. Our mission is to improve health and reduce health inequalities throughout Europe, to bring together the diversity of the public health community, to provide leadership and facilitate change, and to build public health capacity. And the vision that we have goes beyond Europe, because it's also tied to certain values: inclusion, diversity, global health, etc. So, I mean, we're taking the broadest possible sort of new public health approach. So I already mentioned a little bit about our members. I think I don't need to mention that again. I didn't mention the risk factors. There's also organizations working on alcohol, tobacco, different health determinants, of course. And they are active either in their own rights as platforms based in Brussels or elsewhere in Europe. So they are membership organizations in their own rights, or they might be smaller public health related platforms operating in the member states. Enya mentioned Malta. So for example, the Malta Health Network, I know, is quite well connected to the Maltese government and to the hospitals and stuff, probably also to the schools. But they are quite fortunate because Malta is a small country, so everybody knows each other, is my impression. And in some of the larger countries, if you don't really have public health specific platforms, it's not so easy to identify who's actually working on public health. I'm not going to spend much time on this, but just to say, like any NGO, we have a board, we have a general assembly that meets once a year. I'm the leader of the secretariat based in Brussels, where we have 11 staff, including 5 policy staff, and we have a president who's representing the European homelessness platform FIANSA. And how do we work with our members on a day-to-day basis? Well, we group them mainly into working groups. And the working groups, they're meeting maybe 1 to 3 times a year, depending on the issue. But we also have bi-monthly policy coordination meetings where we talk more strategically with whoever is available at that moment in time to see what are the upcoming opportunities and challenges for public health. Finally, we're going to have one on the COVID crisis next week, with a bit of a delay because it took us a while to adapt to the new situation and the new ways of working as well. Let's not forget about those. We have directors meetings, again, sort of more strategic inputs. And then we have scientific advisors that are helping us with compiling the evidence base or guiding us towards relevant papers and policy documents as well. And then, of course, I mean, I mentioned that my background is in communications and cultural studies. Communications really is what advocacy is, let's face it. Communications is a large part of our job. For that, we have a small communications team. And just like EMSA, we communicate via our website. We're active on Twitter, Facebook, LinkedIn. We have specific newsletters, a monthly newsletter, members' news feeds, and these kinds of things. And just the last word on EPHA, which is our finances, because I think this kind of determines, unfortunately, a little bit the types of advocacy that we can successfully do. Because like everywhere else, the more money you have, the more you can do. Given that we do not currently wish to have industry funding, and we depend by and large on an operating grant coming from the European Commission under the Public Health Programme, plus another 40, it says here, but let's say up to 50% of grants coming from international foundations or through other types of national or EU projects. That obviously ties our hands a little bit in the scope of activities that we can do, because you can imagine that with 5 policy staff, these people are busy also implementing projects on a day-to-day basis. I think we don't necessarily need questions already. Let's move on to advocacy and then have some questions after this part, unless you have any super burning questions. But I think the important thing to know, and I'm sure many of you know already, is that advocacy means different things to different people. And if you look at the word, my understanding is it probably comes from advocare, so to sort of speak on behalf of somebody else. But I also know that advocacy is really difficult to translate into a lot of languages, including my original language, German. I wouldn't even really know. I think it's Interessenvertretung, so supporting the interests of others. But basically, I was looking at some definitions, and given that we're working with the Open Society Foundations, and sometimes in the past we've worked with UNICEF, I was looking at their advocacy toolkits, which, by the way, I encourage you to read. So it's an organized, it could be seen as an organized attempt to change policy, practice, or attitudes by presenting evidence and arguments for how and why change should happen. I think that's a pretty good advocacy definition. I also like the UNICEF one, which is a deliberate process based on demonstrated evidence to directly and indirectly influence decision makers, stakeholders, and relevant audiences to support and implement actions that contribute to the fulfillment of rights. And that's the reason I picked this one, because I wanted to make sure that it's not only about health as such, it's also about rights. So what does an organization like EPHA do on a day-to-day basis? Yes, we lobby. We may not necessarily call it always lobbying, because lobbying to me always sounds a bit like the pharma industry or the tobacco industry knocking on policymakers' doors, but essentially that's what we do. We meet policymakers and we bring forward positions. And some of the meetings are formal meetings that we request. Some of them might happen informally during events and conferences, and then we maintain the contact and we try to influence people around the people who are taking the decisions to make sure that they understand what we want to achieve, because those people are probably holding the key. Or we invite them to our events, to get to know each other better and see where we can find consensus. So the ultimate goal is to influence policies from their inception to their implementation and evaluation. So different stages of the policy cycle, I'll get to this. It means nurturing long-term relationships. Unfortunately, no real one-night flings in advocacy, because people change, which means that you also always need to ensure a very smooth handover when transitions do occur. And obviously we had a big transition last year with the new parliament, the new commission in place, and we're still getting to know some of the people working on the files that we're working on. We want to provide thought leadership. But sometimes we also just want to do more campaigning. If we have specific issues where we're trying to raise awareness at multiple levels, so not only policymakers, but perhaps also among the general population, among our partners, among students, then a campaign might be a little bit better because it makes a bang. Whereas the thought leadership is obviously embedded in a longer process of, studies, getting evidence, working with members, etc. We want to activate the power of the network. I mean, Rana, in her opening statement, she said that EMSA is working at the European level, at the national level, at the local level. But how do you do that in practice? We're lucky because we have members who are active at all of these levels. But nonetheless, we need to find synergies between what they're saying. Very often, it's far from clear what a certain EU policy means at the national level or at the local level. Same goes for building coalitions with partners. Depends on the problem, depends on the opportunities at stake, I would say. Sometimes it's much more effective to work in partnership. For example, we do that through the social platform, which regroups some other big platforms like EPHA. Sometimes we want to go our own way because the problem is public health specific. Working with our members needs to involve empowerment, because if we don't build their own capacity, let's say these small organizations that I was talking about, particularly in the new member states where public health is, yeah, I mean, it's there, but it's kind of spread between smaller groupings working on specific issues. We need to help them to create a voice, and also to bring that voice to Brussels, ideally. And then, of course, really important in advocacy is that whatever evidence and arguments you're putting together through your activities, your research, your surveys, etc., you want to convince policymakers, decision makers, why change is needed. Because if you don't know why the change is needed, then you're not going to be convincing others. And that might also imply working with the media, not only to amplify your messages, but also to make sure that there's a kind of coherent message being told across the different territories that you're active in, but also to establish your own expert voice credibility over time. And one thing I would say probably the biggest take-home message is that policymakers are not really looking for the nag that complains all the time and knocks at their door and says, well, all of this is terrible. You know, health prevention funding, only 3%. What are you doing? Why don't you realize this? But they want to see solutions, concrete proposals, rather than complaints. They want us to be delivery partners and not nags. So I won't have time to go into this. I've taken this, I think this came from the OSF guide that I mentioned. They have an advocacy guide that kind of explains the different steps that are involved in the advocacy cycle. One of the things though, because EPHA, you know, I mentioned, I think we have 11 staff. So already we're limited because these people are busy, much busier than you'd think. So that kind of strategic approach, having a very clear multi-annual advocacy strategy that maps out objectives and goals in the interim, like in the short term, in the medium term, in the long term. Yes, I mean, we try that from time to time, particularly when we're trying to develop a new strategy for the organization. So right now, for example, I'm looking at this because EPHA's 5-year strategy is coming to an end. So I'm looking in more detail, like what are the next areas we'll be working on with our members, with the team, with the board. And that involves probably objectives over time. But to be honest, advocacy strategies, most of the time, we don't actually, I mean, I'm not saying we don't have them, but we use them in a more ad hoc way. And that is mainly because we need to be extremely flexible. So we probably have a shell of an advocacy strategy because we want to know what do we have already, what is it that we want, what kind of activities would be most impactful. We can do a kind of SWOT analysis as well. You know, what members, what partners do we have, what kind of financial resources, human resources, etc. But ultimately, for smaller organizations like EPHA, it doesn't really work to be too rigid because we need to be flexible. We need to be, on one hand, reactive, because let's face it, just because we have, let's say, a little bit more privileged access to some policymakers being in the heart of Brussels than some others, it doesn't mean that these policymakers happily share all of their activities and plans with us. Quite the opposite most of the time. So we need to be reactive, but more importantly, we need to be proactive, because in order to know what they want to do, we want to have time to talk to them. So the advocacy strategy changes over time and is constantly being adapted to the point where perhaps it's more of a mental thing than a written kind of strategy. And again, just to say also that I think certain actors are better placed to bring forward messages than others. Sometimes the mere fact that you are a public health umbrella organization gives you legitimacy to talk about public health, even if you don't know the topic you're talking about particularly well, whereas a specialist organization working on cancer, working on cardiovascular, working on, I don't know, Roma health rights or something like that, they might actually know more about that specific topic because they've been intensively working on it. But the voice is a different one. It comes from a niche. So sometimes you want to work through your members. Sometimes you want to work as EPHA EPHA speaking as EPHA. I'm not going to go through the slides here. I just wanted to show you that there are many, many different types of outputs / deliverables that we then produce, from briefings to position papers to open letters, case studies, reports, videos, social media, exhibitions, you name it. And then you were probably wondering, well, okay, so working in coalition, what do you mean? Like, do you mean working in coalition then with the European institutions, or with whom? It could be. Ideally, we would work in a coalition already with the European Commission when it comes to the development of new pieces of legislation, let's say, or new action plans. And also with the executive agencies. So for health, we have the EMA, the European Medicines Agency, now based in Amsterdam. There is the European Center for Disease Prevention and Control that you'll find in Stockholm. There's the Food Safety Agency in Italy, and other agencies with health-related missions. I'm thinking of the Fundamental Rights Agency as well in Vienna. Of course, in a way, we're working with these, but perhaps they aren't our natural advocacy partners. They are the audience of our advocacy. And the same thing I would say for the European Parliament. Sometimes MEPs already have clearly defined interests and activities in mind, and then we can work more on an equal footing. Sometimes we need to actively convince them to get there and to do something, but if they do something, then it can be very powerful because they are obviously the political representatives in this policy game. But other partners could be, I don't know, the permanent reps representing the member states in Brussels, or embassy officials who have then the arm to the member states directly, because let's face it, it's not only about what people are doing at the Commission and at the Parliament. The political will needs to be created, and the political will needs to be created back at home in the national capitals. There are so many international organizations with Brussels offices as well, from WHO to you name it. We can work with local and regional authorities on certain issues, depending also on the structure of the health system in certain countries. The social partners, so the trade unions, for example, think tanks, chambers of commerce, trade associations, other NGOs mainly. Which brings me to you, medical students. I think students in general are just super important. For many reasons. I mean, again, I'm trying not to read this out. I'm just very forgetful. That's why my slides are busy. But not only do you have expert knowledge as as future medical specialists, let's say, or generalists for that matter, or public health specialists. So already coming from that angle, your voice is super important in health. But more importantly, your knowledge is based on everyday practice and on evidence. So some of you might be more research oriented, but most of you will be practicing medicine, let's say, or a form of health in your everyday lives. So I think especially where the evidence base is weak, I mentioned evidence plus argumentation. And I think argumentation is as important as the evidence, because let's face it, evidence is also being created where it can be created and where it is funded. So we know a lot of things about certain groups, let's say, but we don't always have the statistics in place. So you can also speak from a practice argumentational base, which is a real plus, I think, a real asset. You have direct contact with patients. You might be future public health champions. You can influence the future direction of education and training for your professions. Fantastic. You're at the heart right now of the digital transition in health and care. You'll know what works and what doesn't work. You can build bridges, and I know many of you are keen to build bridges with other healthcare professions, be it the nurses, the pharmacists, or whoever else is entering that sphere. You have, and please don't take it in a negative way, but you have a privileged voice. As medical students, or as law students as well, you sort of have an authority and a reputation. If you're looking at politicians' CVs, many of them are doctors, many of them are former lawyers. It gives you a certain authority in society, which gives you also a unique opportunity to speak on behalf of those who don't have that voice, who don't have that privilege, let's say. While you're struggling to pay your tuition fees right now, I know, but anyway, yes, and you should, I mean, ideally you can work through organizations like EMSA or like EPHA or like the CPME that was also mentioned and be the change. I want to move on and talk a little bit about COVID and the opportunities coming our way. Probably won't have time now to talk about all the gaps that were exposed, but I think we've all followed the news every day and we continue to do that. One of the things that clearly came out, huge differences between health systems in Europe, huge differences in how the pandemic crisis was communicated, huge differences in how data is collected, huge differences in the capacities of health systems to, I don't know, make hospital beds available, treat non-COVID patients, excuse me, side by side the coronavirus patients, huge differences in what pertains to the supply of masks and testing and equipment, etc. So really, it seemed to a lot of people that perhaps the EU was a little bit missing in action, which is obviously not true, but very quickly the crisis turned into a very national debate. I was quite conscious of that and a little bit not shocked, but surprised, I would say, because we also know that more and more people are pushing. We'll get to this in a moment. More and more Europeans see definite value in health being a sort of European competence. Nonetheless, all of a sudden you had heads of state, ministers, virologists, experts speaking purely from the national level and looking at national evidence. So yeah, unfortunately, we will now see what are the hidden impacts of the measures that were taken. We will hear about the things that were not so much discussed in the media. And of course, we have, unfortunately, this looming social, economic, societal crisis to look forward to, which, yeah, is going to have a long-lasting impact. And unfortunately, probably most on those countries that were already very weak, just coming out of the financial economic crisis. So maybe this would be a good moment to have some questions if you have any. I'm hoping silence means no and that you can hear me. Maybe Rana, if you could just tell me that you can hear me.
Oh, absolutely. We can hear you. Yes.
Fantastic.
So if you have any question, just feel free to ask now. Write something in the chat so I can unmute you if you don't object to the recording. And otherwise, just write it in the chat and Sascha will answer your question.
Yeah. I'm happy to move on. I probably won't be able to go through all of my slides, but we want to go to the opportunities. The scope of public health policy. I think what I'm taking, why I put this together is because on one hand, it's science, on the other hand, it's art. So we want to be the Kraftwerk, the Laurie Anderson of health, trying to understand both and put them together in a way that makes sense and that kind of reflects the organized efforts of society. I think the WHO refers to it as an all of government, all of society effort is public health. So it's extremely multifaceted. And that's why EPHA, for example, but many of our partners as well, are very much into this health in all policies principle that kind of describes that while there are many, many other policies that are not health policy impacting health because of the diverse determinants of health, those people shaping those policies need to be aware that health plays an important role. And again, returning to the COVID crisis, I think the understanding that the economy and health are intimately connected. I mean, we've known that, you've known that for many, many years, but I think at least now it's at the forefront. Everyone is considering that seriously for the first time in years, which is fantastic. After years of health being one of the small things at the European level, now health is probably one of the biggest things, and that's a huge shift in mentalities. maybe you've seen this throughout your studies. This is just to show, you know, like the different layers of health, the more societal layer, the living and working conditions, the social community sphere, individual lifestyle factors, and then how that impacts the individual. So these are all the different prisms that we're working on. And then I mentioned the policy cycle, which is kind of related again also to how we do advocacy. So from the identification of the problem to evaluating policies at the end of the policy cycle, once we've seen what they bring or not. One of the main things, I'm sure you're also being confronted with this time and again, is that the EU powers in public health, according to the treaties, are relatively limited. Again, in the COVID context, yes, Article 168 of the Lisbon Treaty specifies public health competences in the sort of cross-border healthcare coordination sphere, with a limited scope to introduce legally binding measures and EU-wide harmonization. But most of the public health relevant pieces of legislation, they are not based on this Article 168, but they come through single market legislation. So thinking about tobacco control and other important pieces of organization, they're not necessarily because of a large health-specific competence, but competences in the areas of environment, taxation, consumer policy, agriculture, trade, and so on. So that's really interesting, because that means, of course, we need to speak to policymakers in these other areas, and that's an added burden because obviously there's also a DG Santé, a health director general at the Commission in Brussels, with whom we also need to speak, and they are coordinating a lot of these health and all policies activities, but at the same time we need to also influence all these other people, and that is very time intensive. So yes, prevention, important. We'll get to that in a moment, because I think I've already covered some of this. National governments, on the other hand, yes, countries are sovereign. They are responsible for the health of their citizens and people, and but they do need to take into account European law and international commitments. But sometimes the international market can also limit national action in good and in bad ways. So it's a complex interplay. Again, this could be the subject of another presentation, but EU can regulate across national levels, but often national action is needed before the EU even kicks any legislative thinking into place. So that means, again, EPHA needs to be present at the national level through our members, at the European level by being part of the dialogue. Yes, and I mentioned already, I'm just going to focus on the bold part here, the uncertain future of health in Europe. But now we really have a huge opportunity. Why? Because potentially billions of new funding will be made available as a result of the pandemic crisis in the area of health, hopefully also more specifically on public health, and not only for pandemic preparedness. Nonetheless, this is the declared ambition, but we need to also make sure now that political will, and again, this is at the member state level, matches that declared ambition at the European level, let's say. So we want to seize the momentum. The opportunities are amazing. An increased understanding that prevention is key, not only in terms of the activities that prevention might involve in the different areas that you're working on, but also in cost terms. So that's definitely prevention, health prevention, the core mantra of public health. We need to make that point again now, and we need to shout it off the rooftops. There's talk about an expanded EU mandate in health and or better use of existing powers, because that health mandate has been very narrowly interpreted during the COVID crisis. I think, there's probably more stuff that could have been done, but given that, it came in a very sudden way, and then member states were different phases of the pandemic, it became harder and harder to harmonize activities. resources for the executive agencies should be bigger. Some people are calling for an EU health union even to put more structure into joint procurement activities, joint surveillance, preparedness, etc. You will have heard about the Merkel-Macron recovery plan proposal to kind of make sure that this solidarity gap closes or doesn't arise in the first place. But there's many other opportunities, and these are related a little bit to the new Commission priorities that were already announced last year when the von der Leyen Commission came into place. In healthcare specific, this was before the crisis, so it was about supply of medicines, it was about data-driven healthcare, it was about antimicrobial resistance, vaccine hesitancy, Anya's field, the creation of Europe's Beating Cancer Plan as a sort of blueprint for NCD prevention, the farm to fork strategy, which is a part of the Green Deal, and that is much bigger than only food production. Implementation of the medical devices regulations and endocrine disruptors, just to give you some areas. And EPHA was already working on those priorities, but now it's getting broader with the Green Deal. It's about energy, it's about smart transport, it's about air pollution. It's about, the other priority is about social fairness and prosperity. So things like minimum wage, unemployment and welfare benefits, anti-discrimination. So these are important issues as we're coming out of the imminent health crisis, moving into the social economic crisis. You know, a child guarantee, healthy and active aging, these kinds of things. Digitalization, the role of digitalization. Some of the EMSA students took part in my working group on digital healthcare the other day, and it was really nice to have them there because they really emphasized the importance to adopt an ethical approach to the opportunities afforded by data-driven healthcare, namely artificial intelligence, for example. It's also about skills and building up digital literacy and health literacy, whether it's digital on or offline. And ultimately about democracy, preventing populism. All of these are layers that can influence public health. And in the global context, if we are now moving from one crisis to the next, this will have an impact not only in Europe, but ultimately also for the achievement of the Sustainable Development Goals. So there's the global layer of our work. So some short examples, because I know I only have 45 minutes and we do want to make it a little bit interactive. So rather than going into big details, I'm glad that my colleague Anka of the Smoke-Free Partnership is also doing a session on the Tobacco Products Directive, because I did have some slides on this, but it probably would have consumed the entire session. So brilliant that she's doing that. But that's obviously a big success, let's say, for the public health community that we have this directive. It may not be perfectly implemented in all countries, but nonetheless, it's there. Similarly, at the national level, there are these so-called sin taxes on sweet or fatty foods or alcohol products. And there we're working more at the national level through our members. And I don't know whether it's Ireland or Finland or countries like that. They've successfully introduced bills over recent years. And we kind of build a repository of case studies that we are then bringing in turn to the European level. Most of our successes are probably harder to, less tangible, not so visible. For example, sometimes it's small things like the mention of health in the new Common Agricultural Policy. After years of not really making a connection between food production and health, now the link is very clear and we can work with that. Changing the narrative on the business model for medicines patents, and now also making a case for vaccines as public goods. That's a really important piece of work that we're working on. And of course, that involves stakeholder dialogues with policymakers, but it also involves conversations, crucially also with industry, with patient groups, with all of the NGOs and networks that are pushing for access to affordable, accessible, etc. Medicines in Europe and worldwide. Similarly, when I started working on digital health, to be honest, nobody was talking about health inequalities in the context, in the online context. It was just a given that everybody has access to a computer, that everybody knows how to use a computer, and that everybody is able to sort of find health information online and work with that. And we all know that that's not the case. Even, you know, in my own family, my father, he's 75 years old, which is not ancient, but you know, he didn't work with computers, and he's only just learning to use them, and he is not able to find quality health information online and to take decisions based on that. Other examples would be thought leadership, for example, on food systems, on healthy living environments, on the interconnections between, let's say, communicable and non-communicable diseases, the interactions between clean air, NCDs, and let's say even COVID-19. So establishing new connections or making sure that those connections are heard. Thinking about the needs of specific communities such as Roma. We are working on projects funded by the Open Society Foundations, and of course, again, the health needs of some of Europe's most vulnerable communities, where access to sanitation, safe housing, water, etc., is just not a given. You know, how do people engage in physical distancing in these communities? They don't. So these are some of our kind of successes, if you want, but really this is all part of an ongoing dialogue. It's difficult to measure. Obviously, we have certain metrics in place. You know, like we're counting the number of policymakers that we've convinced that an action needs to be taken. We're counting the number of new partners that are joining us as part of a campaign. We're counting the number of responses that we've received on and offline in response to our documents, but ultimately it's probably something that's very hard to measure, and you only see it over time. And now for some reason, yeah, okay. Sorry. Just to give you a short example for this, of a current campaign, that's the last thing I'll talk about, which is Clean Air for Health, because Rana told me that some of you might be interested in this. Unfortunately, we don't have time now to play a video here, but you can find it on our website. So this is just to sort of show the levels of air pollution in selected cities around Europe and the impact this has on lung disease and cancer and related types of diseases and NCDs. And basically, we wanted to make the point that there is already a strong and robust evidence base out there, thousands of studies. Air pollution affects every organ and virtually every cell, so even prior to birth. And it is worsening health inequities or inequalities because the most deprived areas are usually the most affected by air pollution, be it because they're close to factories or areas that are highly populated with a lot of cars. And you see a clear east-west divide on this topic as well, which is quite shocking. But I wanted to use this example because it kind of neatly shows the policy context, the multi-layered nature of our work. So we saw policy opportunities at the international level, so working with WHO, because they are working towards a legally binding treaty on air pollution. And they were doing a scientific review and fueling then the climate emergency movement. But there was also stuff going on at the European level. So in this case, the outdoor air pollution EU legislation, new standards for vehicles. There was increased EU action in the wake of the Dieselgate scandal. And there was also a big conference, well, I took this slide from one of our colleagues, but there was a big conference on clean air in Bratislava, which then triggered the dialogue. But importantly here, there's a lot of activity going on at the national and at the city level. And for us at EPHA, this is great because A, it's an opportunity to bring in our members working in Poland, working in Romania, working in Slovenia, I think. I'm trying to think of some Western countries now, but I think in the Netherlands as well, to conduct research, to disseminate advocacy messages, to be actively involved in meeting policymakers, building local coalitions. Spain, of course, is one of the countries. and work on national emission plans and come up with some concrete policy proposals, basically, and react and also be proactive, as I said earlier. And again, these cities, they are then linked to the international level via the Healthy Cities Network. So there's a really good interaction of partners. And to round off, there were some milestones. So this is an example of a campaign. And it's a campaign because of these different elements that I've just described, and the fact that we have some external funding for this. So we are working in collaboration with the European Climate Foundation on this, and with Greenpeace, a kind of related project, which means we are quite well equipped to produce more attractive, innovative, let's say, advocacy materials, and also translate these into national languages, so it can be used across Europe. But it is kind of like a rare thing that we have these sorts of resources. And the question mark when you have a campaign that's successful is what happens once the campaign has sort of come to an end, once the funding dries out. Does that mean that the topic gets parked or shelved, or can we successfully integrate that topic of air pollution into one of our policy clusters? So I think, yeah, I've come to an end anyway, but that's also, I didn't practice. That's pretty much what I wanted to say. And I hope we have a few minutes more than 6 o'clock to have some questions. That would be really great. Thank you for listening and for your interest. I'm really chuffed.
Well, thank you very much for this interesting talk, Sascha. We'll go for Sophia with questions. A second.
I'm unmuted, thank you. Thank you so much for the presentation. It was really, really helpful. I think it's always nice to refer to diagrams and stuff and how important advocacy is in public health and in general in policy making. I was wondering, you talked a lot about communication, and I think, I'm not sure if I'm the only person in this, but I often feel that communication is super ambiguous, and when it comes to policy, I don't know what the best way to communicate with different people are. And I know that you sort of have to obviously adjust to the person, but I was wondering if you have some tips on effective, let's say, communication and policy making, because that's something that I'm sure we all want to know about.
Sure. I mean, and that's a really good question, because that kind of reminded me that I had another slide which I've taken out, which was sort of like to target the message, obviously, to the audiences you're talking to. Because what does communication in policymaking mean? Well, it really depends on who you're talking to. Obviously myself, I adopt a different style of communication now talking to you guys, a little bit more leisurely, but I did put on a shirt and a tie nonetheless. But obviously I would be acting quite differently if I was meeting the health commissioner or let's say the finance commissioner today, not only in the way I present myself, but also in the way I communicate things. The issue of having good evidence at hand, I think, is particularly important when it comes to formal policymaker meetings, because they depend on information being brought to them. And as you know, the health harmful industries are extremely active when it comes to their lobbying activities, and they are all over. Well, obviously I'm speaking from the Brussels bubble, as we call it, but they are all over the Brussels bubble, and they have much more privileged access to policymakers, even during Corona times. Obviously, partly that's understandable. Jobs are now at stake. A lot of people are jobless, or they're being furloughed, whatever. So, I mean, I'm not entirely surprised that industry is having an easier time. But at the same time, when we do have the opportunity as civil society then to connect with policymakers, we need to make sure that we quote the most relevant and robust evidence there is. I don't know if that answers the question. That is in relation to senior policymakers. When it comes to building coalitions, I think there is also, and I mean in policymaking in general, there's an element of diplomacy, because you don't just build a coalition by saying, hey, we're EPHA, we're working on public health, you're working on, I don't know, migration or something like that, and we're now interested in migrants' health, and therefore we think you should be joining us, and we're going to do some joint statements together. Obviously, you want to be well informed about what the specific, and I'm sorry for that EU jargon, it's just because I work in the bubble, what is the added value that we're bringing to this? Like, what is the specific element that EPHA can bring to a certain issue? Because ultimately, every public health issue that we take on is based on a decision. We don't have to work on these issues. We do have choices, but if we make a choice like that, we should know what it is that we know that our members can contribute to this. Because it's not enough to say, well, yes, I think migrants' health, for example, is really important. Thinking now about, I don't know, the migrant influx in 2016 or whatever, when everybody wanted to work on migration, we kind of decided not to work too much on migration, because we were pretty aware that within the membership, while we do have some members working with migrants in Greece, for example, it would be quite hard for us to access all the right knowledge in a timely way, and more importantly, to bring these members on board, because those members, they were super busy working on the front line with people arriving in Greece at the time. So we knew that we would have had to build a coalition to give us the knowledge to speak from the public health angle on that issue. And that seemed like a waste of resources. So rather than spending a lot of time on this, we were commenting on it and weaving it into some other issues that might have been more important at that point in time. So for example, the issue of, and I know it sounds very far removed now, but in the COVID context, it isn't, the issue of antimicrobial resistance, making that link between infection prevention and control measures again, whether that's at the hospital level or in terms of living conditions, and the fact that vulnerable groups might be more at risk to should there be an outbreak of bacterial infections in their communities or in badly resourced hospitals.
Yeah.
So again, yeah, target the messages to the audiences and bearing in mind what they know. Nobody likes to be told that you know better.
Absolutely. Diplomacy is a good skill, I think, in all walks of life, but definitely in policy making. So we'll try and ensure that actually. I asked also because we're hosting as Health Policy a little group of webinars called ePolicy 101, and we're going to be sharing a lot of the work that was done by previous teams in terms of building up capacity. And I wanted one tiny little question. Mm-hmm. I'm not sure whether, I'm asking this because I sort of feel at EMSA we also kind of get to a point where we don't know how to do this, but how do we mobilize people our age and in general to be interested in policy? Because I think it comes across as something super boring, but honestly, since going into the pillar, I realized that it's not, but before I was equally as bored as I think as everyone is by the sound.
I can totally understand this. Like for me personally, like I said at the beginning, like my kind of trajectory was that I was working in the public sector for a while, and I happened to be working with a team of policy advisors in the education field. And that was the first time I was personally exposed to sort of policy making. And I was like, okay, it's really interesting what they're doing, but excuse my words, I couldn't care less about the topic. Not entirely true, because now I see, like, for example, when it comes to influencing health professional education, I think it's really interesting. But just to say that I know where you're coming from, but unfortunately, if it's so hard to sort of bring young people to organizations such as EPHA, then obviously we need to come to them. So, I mean, unfortunately, this is the best answer I have right now. We need to make more of an effort that we maybe reach out to people who are non-traditional people to get involved in policy, because one of the things that I found really fantastic in a way, and this is another, I think this is a personal advocacy success, is when you see, for example, that as part of a really rigid and boring process, like proposing amendments to legislative proposals, and you then see that the wording that you've proposed has been adopted almost word for word in the medical devices regulation or the clinical trials regulation and stuff like that. Although still, like I say, I'm not a medical professional. These are not topics that I'm easily, that come naturally to me at times. But seeing that the work I've done in coalition with members and non-members to arrive at some kind of wording and terminology that was kind of also basic enough, because the policymakers are not experts. Let's remember this. So the language usually has to be fairly basic, but it still needs to be part of the jargon to sort of fit. So seeing that word for word something got adopted is a real success. And then you think, oh, maybe I can make more impact on policy making than I thought I could. Yeah. So
cool. Thank you. I'll try and include all of that in our upcoming things. Thank you.
Thank you, Sascha. We have at least 2 more questions. One from Umut in the chat, and it's about what European institution to target or to approach when advocating. And then there's another question from Stella, which I will unmute after you answer.
Okay. I'm not sure that I understood the question. So working with the institutions?
I think the question is, as a European NGO, do you go to members from the Commission to lobby?
To lobby. Yeah. Yes, I would have to say that we do that within bounds. It's a very strange turning point now, because the new Commission, from what I see, even before the pandemic crisis, through the priorities that I presented, seems to have a much bigger ambition on health and public health, which also then reflects that after years of this, not investing in prevention, sort of shoving public health under the table among the small things, which was the Juncker Commission, unfortunately. But I mean, again, there's also a reason for this, because we were coming out of the economic and financial crisis. So yeah, unfortunately, some bad political choices were made, austerity politics, and then health budgets were slashed, and that was then reflected in health not being important. The new Commission seems to have a much better understanding of that to begin with. So in a way, does that mean we need to speak more or less with them? Actually, I think it means we need to speak more with them, because the previous Commission, it was clear that while you had individuals, this could be the head of a unit, this could be an issue leader for a certain topic, while these people were clued in, because let's not forget also that people working at the European Commission have all kinds of backgrounds. Some of them come from the NGO sector, some of them might be medical students, many of them are certainly law students. So the individuals often already understand what you're saying, and they would like to instigate change. But if you have clear orders coming from the top, which seemed to have been the case the previous Commission, then unfortunately you can speak as much as you like with these individuals, you're not going to be achieving much. So actually now that you have a group of like-minded people, again, I can only say we need to seize the momentum. We need to make sure that everybody speaks that language, because otherwise we're losing a real chance.
Thank you. Umut, I hope that answers your question. Thank you. Then I'll unmute Stella for her question.
Yeah, thank you for your presentation. It was really interesting. So I had a question kind of more personally, maybe. Since you are so involved in all these public health issues, I wanted to know kind of what you think personally is the most, I guess, underappreciated public health issue at the moment, and what you kind of feel like we could do to increase advocacy in that area, and what is kind of not being done at the moment.
Yeah, that's a really good question. Thank you. Thank you, Stella. To be honest, I haven't really asked myself that question recently. I think mental health. No, mental health. Because I think, again, different layers to this. We have the digitalization of society, and we see that while on one hand, again, there's this huge opportunity to work with all the things that new technology facilitates. At the same time, there's the flip side of the coin, where we also notice that it hasn't really brought that kind of Star Trek world where you press the button and you have things coming your way quite easily, and you have all this time, this extra time. People are working harder and harder and longer. Partly because they want to also, but it's obviously it has an impact on mental health. And a lot of people also feel threatened by the new developments. Again, going back to the digital health sphere, there are very different attitudes towards data protection across Europe. Many people are very concerned about cybersecurity threats because they don't really know how to use technologies properly. And if they're constantly being asked for passwords and logging in here, having 10 applications open, it makes, it's also a lot to take in. But then the other link I would say now is also in relation again to COVID-19. Knowing, for example, that again, I've heard so many different reactions, even from my extended network towards this. So some people I know are really enjoying this kind of, I know it sounds awful, but some people are really enjoying the opportunity to spend more time at home with their families and children. Because normally they're going to work and they may not see their families much. Of course, it creates an added pressure in terms of homeschooling and managing multitasking things. But there is a level of enjoyment for some people. But then there's the other group that is completely scared right now, because we don't know what's happening. We don't know, is there going to be a second wave? We don't know to what extent behaviors might be shaped and changed in the longer run in terms of social distancing, not being so physically close to each other anymore. Little things like in Belgium normally, I mean, I'm not Belgian myself, but people give each other a little bisou on the cheek, and in the Netherlands as well. So I mean, little things like that. Are they changing because of COVID? And if they are changing, does it, I mean, this might be something banal, but it does change the kind of, the level of intimacy that we have with other people. And then I also know people who are so scared of taking public transport right now, so scared of going back to work, that they're not leaving the house at all. So you wonder, like definitely there's something going on that's much deeper than only the current crisis, but that probably is also connected to so many other issues. So mental health, to keep it short, is an issue for which we also don't really have a European strategy. And I would say that would be really great if medical students could push for that.
Definitely agree. That's an important matter as well. I'm not sure if there are any more questions. I see one more by Thomas about EMSA producing a lot of policy papers, which is true, and how we best write down the medical students' opinion and
how best to do that.
Yeah, I guess for the different audiences.
Yeah, okay. I mean, he's got a point there in saying that we're all producing probably too many papers. I mean, I often wonder, is it always necessary to produce a paper in the first place, or is it really more about this verbal communication? Because so to give you an example, and you probably know yourself, when you are being granted the privilege of seeing then a national or European policymaker, how much time do you actually have with that person, right? I mean, if you're lucky, you're getting 45 minutes, maybe, and that's already EPHA, so we are already very privileged if we get like 45 minutes. But sometimes it could be you basically you have to count that you're getting 15 or 30 minutes. So it's basically a little introduction. What is the main message of your organization on such and such a topic? And therefore, then, the written materials become your knowledge bank that you can fall back on, because it's not only always the imminent noise that a new publication is making, but you're also building up this kind of repository that I talked about, a stock of documents that help to refine your language, I think, over time. And I think the other good thing is also no one's preventing you from correcting, let's say, revising previous positions in light of new evidence or in light of new policy developments. I mean, we do that all the time. If we're working with new partners and we notice, oh, okay, like we didn't really talk about the needs of, I'm thinking right now, I don't know why, about sex workers, for example, which is a group that we don't have represented in our membership, but it's one of the vulnerable groups also right now where that sort of economic activity has fallen flat. It's not really working. I mean, people might be working, but they do it undercover. Whereas in some countries before, this was a regulated formal profession. Thinking about the COVID impacts on vulnerable groups, we will probably be revising some of these messages to think more specifically about some additional groups that we haven't covered yet and who may not be part of our membership, as an easy example.
Thank you. Thomas, I hope that covers your question.
Yeah. In more, sorry, maybe one more thing, in more practical terms, I think what might be a good thing to have actually for EPHA and for EMSA, because as I was looking at what does EPHA actually have in terms of advocacy materials other than presentations, I didn't find too much. I mean, capacity building materials. We obviously have a lot of advocacy materials, but we don't have a lot of guides like the one I referred to earlier from the Open Society Foundations or UNICEF, which is kind of like a toolkit for advocacy. I think this would be really useful to have for any organization in your specific context, because you can pass that also on from one generation to the next.
I would absolutely endorse that idea. So that's a good one. And then I guess we'll go to the last question because we're running a bit out of time. Well, let's have the last two questions then. First from Anya about what links or collaborations EPHA has with other medical students associations, such as the equivalent in Africa, and whether there are any shared activities. And the second question is about advocating in the field of climate change and health.
Yeah, okay. The first question, we don't have direct contacts with medical associations in other continents. In fact, we do have the International Federation of Medical Students Associations as part of the EPHA membership, yes, but we haven't got a sort of active dialogue, unfortunately, with some of the associations on other continents. I think it would be really interesting to have those because, like I said at the beginning, there is also, I think, a forgotten element to a lot of the European public health policy, which is the impact on the rest of the world. And just the fact that, sure, not everything in Europe is going in the right direction, and looking at healthcare professionals in particular, you're probably acutely aware of the fact that the stocks and flows of healthcare professionals, of doctors, of nurses are really uneven across Europe. And of course, they're even much more uneven when you're comparing that, when you're comparing Africa or Asia to European countries. So it would be nice if we had more of an active dialogue. The problem is that our main target audience for EPHA advocacy does remain the sort of EU institutions. And then I would say international, like WHO, Europe, and national policymakers are sort of secondary audiences. And anything beyond that, I think it just stretches our capacities. In terms of the climate change advocacy, well, I mean, that wasn't really a specific question. I think there we used to have a working group which is now a separate organization, which is the Health and Environment Alliance, HEAL, H-E-A-L. You can look at their website as well. They're doing great advocacy on climate change among, obviously, there are many, many actors in this. I think the example of air pollution that I've given is one where it's relatively easy to establish the link with health policy in particular, because of the evidence that's there that's linking the higher incidence of NCD cases with areas where air pollution is bad, traffic is bad, industrial production is high, etc., etc. So we're kind of approaching that topic from the health angle always. But indeed, I would agree that now that we're talking about the EU Green Deal, and I mentioned things like energy, the sort of zero, what is it, the zero emissions ambition, the neutrality target, etc. This goes beyond EPHA's knowledge base. So this would, if our members and board should decide that climate change is going to be one of the pillars, one of the clusters in our new strategic plan, then this will be one of the key areas where we have to build knowledge ourselves and to build partnerships, because it's simply too large to do as a public health alliance alone.
Thank you. Thank you for the good questions. They're quite interesting. And thank you, Sascha, for the very interesting presentation. I think it gives a good insight in what EPHA is doing as a great example in the European public health field. And I think it gave the audience also a clear idea of what's possible and what to keep in mind when advocating for issues in their context, because it might be now at your faculty or at your local level. Could be
just to mention also that there's always an option to do an internship at EPHA if we know in advance. We do have medical students. We have students from all fields, because, you know, let's face it, it's a long time that you're studying, and people like to take breaks out. They want to learn something else along the way, try out different things. And like I said, I think you have, fortunately, an opportunity and a really important voice that counts. So make it heard.
That's very well said. And I would definitely encourage the audience to get in contact with Sascha. I've known EPHA for a while now. I've been at their office. They're very nice and very effective at what they do. Then I would like to close this session by just announcing the next sessions. First of all, we'll have one next week, Saturday at 2 p.m. on developing a vaccine for COVID-19. And this will be with a speaker from the European Joint Action on Vaccination. And on the Monday right after, so the 1st of June, we'll have a session on the tobacco industry targeting youth. So check EMSA-Europe.eu for the sessions and register. Also, if you have any questions, feel free to email Sascha directly. I hope that's okay.
No problem.
And otherwise, you can also contact me via the type it right here, so you'll have the email address. So that will be it. There's a report for this session, which will be shared with everyone who registered. If you haven't, email me and I'll share the report with you. And we'll also have this session which is recorded. We can share it with you if you'd like to. So thank you again and have a great evening. Enjoy the weekend. I think that's a nice kickoff for this weekend. So
yeah, Thanks
you,
to
Sascha.
you, Rana, as well, and for everybody who was part of this call. Really appreciate it. We'll stay in touch. Take care. Bye-bye.
Bye-bye. Hey, Thomas. Thanks for the good questions, by the way.
Yeah, hey, I joined only like an hour late. I'll watch the YouTube video. I had a meditation thing going on at the same time, but I'll watch it.
Well, thanks for coming. I'll close this session now, but I hope to see you next week, Saturday. So
Saturday
bye.
vaccination, guys.
Yes, indeed. Love the enthusiasm. Bye, guys.